patriarchal country, for the longest time, when women were given options for careers, they were either made to become a doctor or a teacher. So for a country this big, while we had a large number of doctors available, 250,000 doctors in totality, 80% of these are women doctors who don't become doctors with the notion that they want to save lives, but they want to become doctors so that they get better hands in marriage. That's an irony that our society faces, being a really, strong patriarchal society. So a lot of these doctors don't practice. Stats say that only 40% of them come back to practicing, and that too after many years. Another challenge that Pakistan faces, a good 15 to 30% of good doctors leave Pakistan for better work opportunities across the globe. So, you'll, for example, see a lot of doctors in countries such as US, UK, and so forth.
Okay, it looks like your connection might have fallen off. So maybe we'll wait a minute and then we'll move to the next panelist if she's not able to join.
We can jump in and maybe go back to her when she comes back to make the best use of time. What do you think, Sarah?
Sure, sounds great. So we'll move on to Julie if you want to introduce yourself and talk a little bit about your background.
Sure. Thank you, Sarah, for having me, and thanks to the Georgetown community. So I'm Julie Cornell. I'm based here in central New Jersey in the United States. I run a consulting practice that focuses on philanthropy, fundraising, and fitness. Um, and as Sarah mentioned, I've worked across many different roles in healthcare and pharmaceutical industries. Kind of my sort of largest amount of time in that space was with the Johnson & Johnson Global Community Impact Team, where I was responsible for designing and managing philanthropic investments, partnerships, and health innovation projects, mainly in maternal child health, which is where I had the opportunity to meet Karima, and also health workforce development. Um, and I think on the sort of personal side of the question around, what has inspired me to take a path in global health, I think the cause that has been most enduring in my life is health, um, fitness, women's health, reproductive health, mental health. And I think by extension of this, the people, and in many cases, primarily women who provide this kind of healthcare. Um, I've had family members pass away at very young ages from preventable causes, cardiovascular disease, neurodegenerative diseases. Um, so that family history is really the foundation of my commitment to health. And I think just as a woman in a country that has unfortunately worse maternal outcomes than it should have, I have a personal commitment to kind of solving that particular health equity issue.
Great, thanks so much. And Dr. Ladhani, if you want to go ahead and introduce yourself, talk about your background.
Sure. Hi, everyone. Nice to meet you. My name's Karima Ladhani. I'm based here in DC, and very connected with the Georgetown entrepreneurship space. So happy to do one-on-ones with anyone who wants to continue the conversation after today. My journey honestly didn't start in global health. I didn't expect to be a global health innovator in any way. In undergrad, I studied math and business, and I thought I was moving into a career in finance. It was when I finally got my dream job on the trading floor that 2 weeks in, I realized it wasn't actually the career that I thought I wanted. It wasn't sufficiently fulfilling to me, even though I loved the application of a lot of the skills. And so, nearing the end of my undergraduate degree, I emailed every professor at my University of Waterloo in Canada who was doing anything science related, because I just had a feeling that that might be something of interest to me. And it felt like a last ditch effort to try something new before I locked in. And one professor replied. I said, I haven't taken any science courses, but I have some connection, or I think that my skills are generalizable please trust me on this. And one replied and hired me for a research assistant job working in international tobacco policy control. And it was through that job as a research assistant that I learned about the world of public health and global health, no less, and realized that that kind of population level approach to challenges around the world was something that really intrigued me. And so because of that, I went on to study public health. But I was really interested in the application of math and business that I had done in undergrad and wanted to find some connection between all three of these worlds. And social entrepreneurship and this kind of global health innovation space really struck me as a place where I might be able to do that, but I didn't quite know how. And while I was in grad school, I learned a lot about a variety of different fields, but maternal and child health struck me as being particularly it just struck me as a place where there were particular needs due to the inequities that exist globally. So many of the morbidities and mortalities we see in maternal and child health are completely preventable, and not just in certain parts of the world, but around the world, though obviously predominantly in certain parts of the world. And I ultimately started Barakat Bundle while I was in grad school as an effort to be able to address these challenges that I saw, but also a way of bringing together these different areas of interest that existed for me. And so I had a bit of an aha moment in grad school that led to the founding of Barakat Bundle, and we can talk more about this later if there's time. And as my career evolved, I was particularly interested in working, on the ground with mothers and children and supporting families. But I also was very aware of kind of the connection between the larger policy space that exists and that shapes the spaces that a lot of our innovation can happen within. And so I started working at the Harvard Ministerial Leadership Program, which was a program between the School of Public Health, the School of Government, and the School of Education at Harvard that worked with government ministers in different areas to support human capital policy development and implementation. And now I work on a different side, the African regulation organizations, but ultimately a lot of my work has centered in these two spaces. One, at the government policy level, to shape ways that we can support human capital and create spaces that are supportive of innovation. And then two, with people, trying to understand their lived experiences and support them and really be able to have that more one-on-one impact that can ultimately lead to population level change. So that's been my journey, and I'm looking forward to learning from you all and sharing more as we're here.
Awesome. Thank you so much. So now I have a few questions for each of the panelists. So we'll go ahead and start with you, Dr. Iffat, if you want to also continue and elaborate on your introduction. And my question for you is about Sehat Kahani's model, and it's unique in that it expands healthcare access through technology in low resource areas, and then also aims to reintegrate female physicians into the workforce, like you were talking about before. And so my question for you is kind of what have been some of the key challenges in scaling this model, both the model that expands access in low resource communities and the model that's reintegrating female physicians, given the social and political landscape of Pakistan.
Yes, apologies that my internet just ran away and I had to reconnect. But I think what I was trying to tell was that being a patriarchal country, this is a challenge that the country was facing. And somewhere down the lane, both me and my co-founders, being female founders, had to choose between having a career or having a family. And I think that's when we realized that one shouldn't have to choose. And every woman, every doctor who becomes a physician with so much hard work, grit, persistence, should be given the opportunity to work. And that's when we created Sehat Kahani with the vision that female doctors who are not able to work fully outside their homes can still manage working while they are at home, maintaining their domestic responsibilities and connecting to people. And that's essentially what we did. As Sarah was very rightly saying, we started the organization by connecting nurses and lady health workers who exist already in low-income marginalized communities and started to connect them to online doctors. And it was very simple, very straightforward. In the beginning of our journey, we would actually connect them to online doctors using Skype, something as simple as a software like Skype. And, the nurses were given laptops, basic webcam that they could connect to their computers. That's how we started. But I think when you talk about challenges, some of the biggest challenges that we faced in the early parts of our journey were that we were working in very low income, marginalized communities. And a lot of the times, the people feared that, okay, these are people that are on the other side of the screen. Who are they? Are they genuinely doctors? Are they making my video or something else? What's actually happening? I think that was the initial challenge that we broke down with a lot of communication and a lot of, workshops, support groups in the communities that we used to do, mohalla meetings, so that people became more familiar with it. Over the years, this challenge and this barrier went away. Even internet penetration in Pakistan became very prominent. But I think the last 2 years, particularly after the political turmoil, we have seen shifts and changes in the internet again. So, in many communities which were already very actively being connected with online doctors in remote communities, now we see a difference in the internet connectivity. It isn't as fluid and as um, you would say smooth as it was earlier. One of the reasons that we have seen is that in the last 2 years, the government has put firewalls over the internet. So that becomes a challenge, and there are, delays and challenges. That's one thing that we face. Again, being an agile company, I think an opportunity that this gives us is that we've created offline modules of our telemedicine platform, which enable the nurses to have recorded the history of the patients and send it to the doctors online in a store and forward program. So I think the biggest learning that I have had over the years is that being a young company, you need to be able to innovate continuously. That's one thing that we have been doing. One more challenge that we used to face much early on in our journey was, again, two female founders coming from a patriarchal country, a very heavy patriarchal country. That was also a challenge that we realized needed a lot of work, which has improved over the years. We've been 8 years in this journey. And I think in the last few years, what we've seen is that gender is now very secondary when we start conversations, but probably that's because we have gained much maturity in our work, in our way of explaining. The work that we do in pitching, that has come over time. So these are some of the challenges that we've faced.
Thank you so much. So the next question that I have is for Julie, and it's basically aimed towards kind of private sector actors. So how can major private sector actors meaningfully partner with startups, NGOs, government organizations to drive innovation and entrepreneurship in global health, given kind of your experience? And because a lot of Georgetown students, I think, are kind of interested in entering this space, what advice do you have to students and other individuals who want to enter the private sector with the goal of improving global health equity and access?
Sure. Thanks for your question. So I'll talk about two examples, one with which I had direct experience, and then another that I just sort of admire from afar. So when I was with Johnson and Johnson, with a very strong focus in improving global maternal child health, we looked to our northern neighbors in Canada and worked with the National Aboriginal Council of Midwives and the Canadian local chapter of Save the Children to improve maternal child health outcomes, specifically in Canada's 450 plus Indigenous communities. Canada still has a policy whereby Indigenous women are actually flown from their village or reservation to a traditional Western hospital to give birth. And this is partly due to a long history of colonialism, and partly because most of those 450 plus villages do not have reliable access to an OB or a midwife. So both Save the Children and the National Aboriginal Council of Midwives approached Johnson and Johnson for a partnership to kind of clear a path to midwifery for Indigenous women. So the innovation here was how do we actually increase the number of Indigenous midwives who live on reservation, who can serve their local communities, who are in community all the time. Some of these villages have a doctor or a nurse on site for a few weeks out of the year. And of course, we all know that healthcare needs don't stop just because there's a doctor not or a midwife not present. So part of the work was working in partnership with different Canadian universities to open up their admissions and really open up their curriculum to Indigenous midwifery students. It's not just about, accepting those students and bringing them through a program, but it's also about how do we fundamentally need to educate these students differently, exhibit different types of cultural competency and teach that cultural competency, not only to Indigenous students, but non-Indigenous students, perhaps about Indigenous birth practices. And then the other part of the innovative model was providing Indigenous women with gainful employment in their communities by providing training either as doulas or lactation consultants, which allows those women to have an income and kind of provides that pipeline to midwifery. And that also eventually involved working with the Canadian government to ensure that these women were getting access to universities, that there was additional government funding involved after private sector funding ran out. So that's kind of one example. And then another example that I've always admired from afar. My dad had Parkinson's disease. My grandfather had Parkinson's disease. So Parkinson's is a cause very close to me. So the Michael J. Fox Foundation acts as a convener with innovators and small researchers and development shops, and then big pharma to de-risk big pharma's investment in some of these smaller innovators who are working, perhaps on the fringes, trying to push the edges of research when it comes to Parkinson's and other neurodegenerative diseases. So it's a model between a foundation, the innovators, and big pharma, and that's a way to actually fund innovation and startups. And I think, what advice I would have to, folks wanting to enter into the private sector with the goal of improving health equity. I think you can do this from a variety of angles. It's not just, the small social impact team that's inside a private sector company. You want to look for areas where you can actually make, I think, a larger impact, whether it's within government affairs, if it's in supply chain, where you're looking at what types of suppliers are you supporting, what types of local or women-owned businesses are you supplying. When you're looking at the life cycle of a product, if you're in that supply chain, is it cheaper to destroy that product or is it actually cheaper to donate it? And then there are other ways that you can work on market access if you're looking at, a product that a government is going to pay for, not have that product be donated. How can you work with local governments on price scaling options for, different types of countries? So I think there's really a variety of ways that you can get involved. I'm speaking more from the pharmaceutical sector because that's where I have the most experience. But you can really get involved on both the commercial side as well as the social impact side to have that impact on global health equity.
Great, thank you so much. So the final question I have is for Dr. Ladhani, and it's a little bit more about your company, Barakat Bundle. So Barakat Bundle takes a community-centered approach, co-designing solutions with local families and local health workers. So my question for you is, how did community feedback shape the design and delivery of your products? Especially given that I think community and working with local communities is a very key way to kind of decolonize global health. So what do you see as the role of local communities in general, also in developing ventures in the field of global health? And then specifically in your experience, how community feedback shaped the design and delivery of your products?
Yeah, for sure. Thanks for the question. I think it comes back to one of the things Dr. Iffat mentioned about trust, right? You could have the absolute best solution that's the perfect match for a problem that you might see. But if the people who need to use it or don't want to use it or don't trust that it will solve the problem for them, then that solution doesn't have the same value that it could otherwise have, and the impact will not necessarily be there, right? And so local community involvement, I think, is the linchpin to address that challenge of trust. In the case of Barakat Bundle, we're trying to address this challenge of preventable maternal and child morbidity and mortality, right? And as I mentioned before, the world already has a lot of evidence-based solutions to address some of the common causes of these afflictions in certain countries, particularly in India, where we work. But a drop from the sky approach doesn't always work. It's not just about getting the items into the hands of people who need them. It's about ensuring that they want to use them and they know how to use them. And so for us, there's this issue of distribution leads to utilization, leads to impact. But utilization is the key piece. So how do we encourage that utilization to make sure that when we distribute something, we actually see the impact we want? And global health, you may have heard of these examples of people gave out mosquito nets for free to prevent malaria, but people use them instead for fishing to get food. It's a very common example. And the issue is that people may need prevention from malaria, but they also need and want food to survive. So understanding humans' responses, humans' actions is really important to designing a solution that can actually address their needs and their wants. And I learned a lot about this concept from a book called Poor Economics by Banerjee and Duflo, which I really recommend. It talked a lot about how you need to understand human behavior and understand that human behavior is driven by wants just as much as needs. And when we're designing solutions in the global health space, we need to understand the humanity in people and what drives their behavior. And it kind of leads to this concept of human-centered design that I'm sure many of you have heard of. For Barakat Bundle, the reason Barakat Bundle came about is because I was reading an article called Why Do Finnish Babies Sleep in Boxes? And it was about a program started by the government of Finland back in the 1930s where they wanted to motivate mothers to receive prenatal care. And this was when Finland was a low-income country. So they provided a cardboard box with a mattress inside, so it doubled as a sleep space, filled with goodies for mother and newborn. And every time a mother completed her full prenatal care for visits, they would provide her with this box. And to this day, the program continues, but now Finland is a high-income country, and mothers can choose between a cash grant of like 140 euros or receiving this box. And to this day, more than 95% of mothers choose the box. And it struck me because there is something intrinsic about more than just your own little family unit caring for the mother and newborn at this phase in life. There was something about a society, a village, a government supporting, and that made people want this box, that made people want to use this box and the items inside of it. And I thought, what if we could adapt that to be a global health delivery mechanism? And adapt it to a place like South Asia, specifically India, where we were working, and use it to deliver some of these evidence-based goods that we know work, but in a way that encourages that utilization that can lead to greater impact. And that's how Barakat Bundle was born from before I even knew what human-centered design was, this idea of a potentially human-centered design approach. But then as I learned more about it, we applied it more and more. So I really recommend IDEO. They have great toolkits on human-centered design. And when we learned about it, we thought, okay, we want to learn more. We have this concept, but how do we adapt this to South Asian families and what they might need? How do we learn about women who are giving birth in these contexts? And we were grad students in Boston with no money. So how do we figure that out? And so we thought, who is the closest we can get to better understand this? And we realized that there were a lot of families in Boston who had grandmothers who had given birth in India who were now visiting their families in Boston. And we literally went around to houses. We used our network and we asked if we could interview these grandmothers. It was not perfect because they gave birth a long time ago. It was a different time, but it was close as we could get at that moment. And we had a questionnaire and we spoke to them and we learned and learned and learned. And the more that we had these open-ended questions, the more we were able to zoom in and refine our solution, our delivery mechanism. Then we applied to grant to competitions at school, which I highly recommend. Access to funds while you are in school. If you're thinking of a startup in the innovation space, they dry up when you're not. So definitely take as much advantage as you can. That gave us our first bit of funding to be able to actually go to India and take it a step further. So when we went, we had ideas. We had talked to all these experts in the Boston area about, okay, based on the evidence, these are the items that should be in the Barakat bundle and that will address these causes of preventable infant and maternal mortality. That's all great. But what do the mothers think? So we bought all of those items from Amazon or whatever, and we literally put them in a suitcase and took them to India. It was not the most cost efficient way. It was just what we could do at the time. And we ran focus groups with mothers where we sat in circles with them at the local primary healthcare centers, and we would hold up each item from something as simple as a thermometer to, a kangaroo mother care sling, to a clean delivery kit, and say, do you know what this is? Do you know how to use it? Do you want to use it? And we would collect their feedback. And then we also created some simple versions of bundles with a few variations, and we distributed them, and we revisited homes after 30 days. To not just ask them about their experience, but to observe their utilization and things like that. And it was from that we adapted Barakat Bundle. And we think that Barakat Bundle is in a constant evolution. There were also some little things that we did that I think were unique for us along the way. So for example, when we wanted to interview mothers and say, how do you feel about your experience and how do you prioritize things while you're pregnant, so we could understand how we could kind of position all of the items, not just to the mother, but also to her family, because many mothers in these situations are living with their mother-in-law, have moved into their husband's home, for example. We couldn't just ask them that. They wouldn't answer the question. It was hard to think about how they prioritize things. They weren't questions that they'd been asked before. And so we used the IDEO approach to say, maybe what we could do is print pictures of different things that a pregnant woman in rural India might do on a day-to-day basis and ask her, which one is most important? Which one is next for you? Which one is next? So by ranking these photos, we could understand how they prioritize their own health and wellness. For example, a photo of a mother resting versus the household chores versus the agricultural needs, and so on and so forth. And so we use some of these different kinds of tools to better understand their day-to-day life, their current experience, how they might interact and use what we were trying to provide them with, and then ultimately to design what we were working on for them. And we continue to iterate and iterate based on our experience from these mothers. So I think it's critically important, and I think part of what's really critical is that unless you are the target market that you are looking to serve, there is so much about that lived experience that we don't know. And so rather than just having an approach that involves doing something and then getting feedback at the end and then iterating, trying to use this kind of community-centered approach to co-design, and iterate along the way can be really critical. And when funds are low, when resources are low, be creative, think outside the box. And you'd be surprised how even when you can't get exactly to the person that you're trying to reach, you can learn a lot about their experience from other avenues and then use that to inform the solution and the innovation that you are trying to implement.
Great, thank you so much, and thank you for sharing those stories. And so with that, we'll kind of move on to the Q&A from the audience. So we have 2 questions that people asked. Feel free to keep adding to the Q&A if you have any questions, or you can use the raise hand feature to ask a question live. So the first question is, for those involved in maternal and child health, what do you see as the biggest problem in this area globally? Is it a lack of advocacy for female patients, lack of resources/access, etc.? And then I'm curious how the biggest problem globally compares to the biggest problem in the US within maternal and child health. So if either Karima or Julie want to take that.
I'll jump in. I think yes to all of the above. Unfortunately, I mean, I think if you look at um, the types of healthcare providers that mainly are treating and caring for women, caring for maternal child health. You look at nurses, midwives, community health workers. These are the types of healthcare providers that are in the shortest supply across the globe. So there's a huge issue with supply. Why is there a huge issue with supply? You go back to government funding and policies around how are you supporting um, aspiring students? How many schools are there available? Are they in areas where people can actually access those schools? Whenever you're talking about any type of social services issue, it is a thread on a sweater. And you need to pull and pull and pull because all of these issues are multifactorial. There's never just one cause to such a gigantic problem as maternal child health. So I think availability and access to healthcare providers is a major issue. I think in the United States, um, the maternal child health inequities are most often fueled by embedded racism and discrimination in the healthcare system. And it's why you have such maternal child healthcare disparities in outcomes when you compare white and Asian women to Black and Brown women and their families. And so, how do you start combating that? I mean, you need to look at the data. You need to look at what are those outcomes at your different healthcare facilities, and start building a picture of, what is happening with these women and these families, and what is the ecosystem around them. Um, Again, is it access to prenatal appointments? Is it issues of domestic violence or substance abuse? Is it issues of transportation? Um, you need to really look at, again, it's a multifactorial issue. And so there's a whole host of interventions at various levels that are needed.
Yeah,
I think let me just quickly add on. I think coming from a low middle income country, I think we are way, far in the progress because, unfortunately, it's a country where a lot of women don't even know about their healthcare challenges. There's severe lack of, education. There's severe lack of information, and there's severe lack of empowerment. So even if they have healthcare access, they are still psychologically, they've been made to made to be dependent so much on their male counterparts, whether it's their fathers, their husbands, any other family member, that unfortunately they don't have even the independence to just walk themselves to a healthcare clinic. And that's what we are trying to change with creating these telemedicine clinics in the heart of the communities. The whole notion is that you have maternal health care in the heart of your community. You don't need a man to walk you to a clinic. It can be a group of 5, 6 women who can just huddle as a group and come to the clinic. That's what we're trying to create, that it's an entirely safe space where the nurse is a female, the doctor is a female, even the coordinator or the receptionist who you may call is also a female. That's essentially what we are really trying to change, that how do you create not only awareness, but also easy access in a community which is very female friendly. We also empower these lady health workers and make them go door to door so that they can disseminate maternal health information to women in households, so that at least they know what they need, what they don't need pertaining to their healthcare, what is it that they need to look out. For example, birth spacing, discouraging early marriages, early childhood pregnancies, all of those things in communities are um, topics which are ridden with stigma in our part of the world, but we try to do it with a lot of, finesse in a way that they don't feel we're trying to culturally challenge them, but that we're really trying to improve their healthcare over time. And that takes a lot of patience and a lot of work, not only in maternal health, but a lot of work in the behavior change as well, which you have to do collectively. Um, if the community works hand in hand with you. So not only those people who are healthcare professionals, but also working with, for example, women advocates from the community, women who hold a certain prestigious place in the community, even religious institutes, for example, the imams of the mosque, or we also work in some Hindu minority communities. So those people who are leading those religious spaces, how can you make them your friends so that they advocate for you and people start really trusting in your work? So yeah.
Yeah, I think that's just to add on to that. I completely agree. I think for us, when we provide health education, it's really important that our products and the materials that we've designed are not just for the mother, but for the mother-in-law and the husband as well. Two other people who the mother sometimes has to advocate. The mother being able to advocate for herself is a challenge culturally sometimes in these situations. So being able to have the husband and the mother-in-law understand so they can also be partners in advocating is really critical. Another thing that's really important when you think about the causes of maternal mortality specifically, often they can be similar, right? We hear about preeclampsia, we hear about infection, but a lot of these things, particularly things like infection, can be addressed and prevented with things like good hygiene, recognizing early symptoms so that they can be addressed. So you may see the similar causes of death on the lists of everything in the US versus in India, for example, but the potential to address them at those early stages of addressing hygiene and things like that is where we have a great opportunity to reduce those numbers in a global perspective. And then access to healthcare so that when we are around the time of birth is really critical. So for us, for example, we focus on hygiene, we focus on health education around hand washing and all kinds of things during pregnancy through that continuum, as Julie mentioned. But then we also provide a clean delivery kit to ensure that during birth, even if they are in a facility, which is great, the facility has access to sterile equipment to minimize that risk. And then we share information with them about danger signs, and we share that with both the mother-in-law and the husband and the mother herself, so that they all are aware, not just of danger signs for the baby, but also for the mother, so everyone can be aware. So we try to address those pieces along that continuum so that we can address it at the prevention stage, at the point of delivery, which is the riskiest day, and then also at that postpartum stage. And so in the US, we may have addressed we may have less impact of some of those, early through pregnancy parts, and we may have similar risk or higher risk, and definitely for certain parts of the population around that childbirth, the riskiest day. But ultimately, a lot of those root issues exist. We're just trying to address them in a large scale across that continuum in all places.
Awesome. Thank you so much for all of your insights. The next question is for Julie specifically. And the question is, did increasing the amount of doulas/midwives decrease mortality in women in the indigenous communities? And was there a need to provide technology and resources for monitoring health and emergency scenarios in addition to just education?
I love that question. And unfortunately, I can't answer it because the program is still ongoing. I think one of the frustrations in some ways about being in the global health space is that change takes time. And to sometimes see some of those key outcomes that you really want to see, like decreased mortality, decreased morbidity, you first need to look at increased health utilization. So Karima talked a lot about utilization. What are they actually doing? What are those practices? What are we actually seeing from a utilization perspective? And it's it's also a long path from educating a new midwife to then that midwife actually practicing in her community. So I think this program, I'm trying to think back to when exactly it started. I think it was 2022. So that was only 3 years ago. So if you go to NACM's website, National Aboriginal Council of Midwives, they may have a little bit more data for you, or the Ministry of Health in the Government of Canada might have a little bit more data for you. Because yes, that is indeed the holy grail, those reduction in mortality rates. but often they take the longest to be able to observe.
Great, thank you so much. So that was it for the questions asked in the Q&A. I'm just going to go ahead and open it up. If anyone has any additional questions, feel free to use the raise hand feature or just unmute yourself and ask the question. So yeah, if anyone else has any questions, feel free to ask. Okay. If no more questions, then we'll go ahead and wrap up. I just want to thank each of the three panelists for your time. Thank you so much. I know I really personally learned a lot. You guys each had kind of different insights to offer, and have different experiences in innovation and entrepreneurship in global health, which is a topic that really personally interests me, and I know interests a lot of students here at Georgetown. So thank you so much for your time. And thank you everyone for attending. This session was recorded, and we'll be posting it on our website and sending it out. So you can kind of go back and watch it at any time. And if you have any questions, you can feel free to you can email me with any questions. I'm just going to put my email in chat. So you can email me with any questions about this event, about the Entrepreneurship and Health Initiative in general. So yeah, with that, thank you so much. And thanks for coming early in the morning on a Monday. And I hope everyone enjoys the rest of your day. Thank you.
Thank you all. Take
Thank
care.
you.